You go to the ER with a sharp pain. After a few hours in a simple scan, a standard IV drip, you are sent home. The relief is short-lived. A month later, the bill arrives for $6,000. Here's the crazy part. The actual cost of that IV fluid was just a few dollars. The blood test, maybe $12. Where did the other $5,987 go? We're told that in American healthcare, the patient always comes first. But in a multi-trillion-dollar system, the money tells a very different story. And today, we're going to follow that money. This isn't just a story about high prices. It's a story about what happens when a system designed for healing becomes financially engineered to extract wealth. At first, I thought this was just about drug prices or insurance games. The deeper I looked, the more I saw a pattern. The money trail reveals a system that has shifted its loyalty from patients to profit. Healthcare leaders are the masters of the reassuring phrase, patients are our top priority. It's on hospital websites, in commercials, and in every mission statement. But a recent study from Yale tells a shockingly different story. Over the past 2 decades, large publicly traded U.S. healthcare corporations spent 95% of their profits, a staggering $2.6 trillion, on payouts to shareholders through dividends and stock buybacks. That's 95% of their profits. Think about that for a second. Funds that could have been reinvested in patient care, better staffing, lower prices, or life-saving research were instead rerouted to Wall Street. Pharmaceutical companies were some of the biggest players, while arguing their high prices are necessary to fund research and development. But the data shows where the money really went. As one of the lead researchers put it, funds are being distributed back out to shareholders rather than being put back into the healthcare system. This isn't a rounding error. This is a deliberate financial strategy. When nearly every dollar of profit from America's largest healthcare companies is sent to investors, it forces us to ask a fundamental question. Who is the real customer here? The patient in the bed or the shareholders on the balance sheet? Let's go back to that $6,000 ER bill. The first stop on our money trail is the hospital itself and its favorite tool, the Chargemaster. For a long time, the Chargemaster was a secret list, but even with new price transparency rules, it's still a notoriously complex and comprehensive list of prices for every single item and service in a hospital. Think of it as a master price list, but one where the prices are wildly, and when I say wildly, they're wildly inflated. Many times higher than the actual cost. That dollar bag of IV fluid might be listed at several $100s. A single aspirin could be $40. We know what an aspirin costs at the store, right? But why? It's because the Chargemaster isn't for you. It's the starting point for a bizarre negotiating game with insurance companies. The hospital sends a bill with an absurdly high number, and the insurance company agrees to pay a fraction of it. Well, based on a pre-negotiated price, right? This lets the insurer claim that they're saving you money, and the hospital can still get a payment far above the actual cost of the item. But here's the catch. If you're uninsured, underinsured, or happen to go out of network, you get stuck with a bill based on those fantasy Chargemaster prices. While laws like the No Surprise Act offer some protection, huge gaps remain in that whole system. It's a system that creates a massive, confusing gap between what something costs and what someone pays. The price is a fiction, but the financial damage it causes is very, very real. The game is designed to look like there are checks and balances, but really, it's just the first layer of a system built to maximize revenue at every turn. The hospital and the insurer are just the two players you can see, though. The real story gets even more complicated when we look at the players you can't. This is where the money trail gets murky, leading us to the powerful but largely invisible middlemen of healthcare. The most influential of those middlemen are the pharmacy benefit managers, or PBMs. Originally, PBMs were hired by employers and insurance plans to negotiate lower drug prices with manufacturers. But today, the three largest PBMs control about 80% of the market and operate in the shadows, and they profit from the complexity they were supposed to solve. They have several ways of making money that can directly inflate what everyone pays. First, in many plans, there's something called a spread. It's called spread pricing. A PBM tells an insurance plan a drug costs, let's say, $100, right? Then they pay the pharmacy only $80 for that same drug and pocket the $20 difference. It's a hidden markup the plan sponsor, and by extension, you may never see. Then there are manufacturer rebates. PBMs negotiate huge discounts from the drug makers in exchange for getting their drugs placed on a health plan's preferred list. But instead of passing 100% of those savings on, they often keep a significant undisclosed portion for themselves. This creates a perverse incentive. A PBM can actually make more money by favoring a more expensive high rebate drug over a cheaper, more effective one. Their profit becomes tied to a high list price, not the lowest cost for the patient. Not anymore. They were supposed to, but not anymore. PBMs, by the way, also own their own mail order and specialty pharmacies, and can create rules that force patients to use their services, boxing out competitors and keeping all the profit in-house. They are the quintessential middlemen, adding another layer of cost and confusion, all while claiming to save the system money. What happens to the people on the front lines when the system they work in is built around profit and not patients? The result is something much deeper and more damaging than simple burnout. It's called moral injury, and that's something we talk about a lot here. The term was first used to describe the psychological trauma soldiers experience during wartime, when they were forced to participate in or witness acts that violate their deepest moral beliefs. In healthcare, it happens when a nurse, a doctor, or any other clinician knows the right thing to do for a patient, but the system prevents them from doing it. It's the nurse who has to rush through critical patient education because of staffing cuts designed to meet a budget target. It's the doctor who sees a patient denied a necessary procedure because their insurance plan deemed it not an emergency, even with the patient in agonizing pain. It's the shame and guilt of feeling complicit in a system that prioritizes transactions over care. This isn't about being tired from long hours. This is the soul wound that comes from being forced to act against your own conscience, day after day after day. And healthcare workers report feeling betrayed by the system that exploits their dedication to patients. They aren't lazy or unskilled. They are trapped in a system that financially rewards speed and efficiency over safety and compassion. And the psychological toll is immense. So how does the system get this way? The answer lies in the incentives. Let's look at the pay gap. One study found that between 2012 and 2019, the average inflation-adjusted pay for a non-profit hospital CEO rose 34% to over $1.3 million. During the same time, the average salary for a registered nurse grew just 2.3%. And a report from one state revealed that the salaries of just 11 CEOs equaled the pay of 572 nurses. What is this massive pay increase rewarding? Research suggests it's not consistently better care. Multiple studies show that the CEO pay is most strongly linked to a hospital's size and profits, not its quality of care or community benefits. In fact, several studies have found no consistent relationship between higher hospital CEO compensation and better patient outcomes like lower mortality rates. Other research has found that in less competitive markets, high prices can raise spending by over 50% with no impact on patient mortality. You are paying more, but you are not getting better, safer care. No, you're not. Even the distinction between nonprofit and for-profit hospitals has become blurry. Nonprofit hospitals are supposed to reinvest their earnings into the community in exchange for the massive tax breaks. Yet many now operate just like for-profit corporations, prioritizing revenue, cutting staff, and using aggressive tactics to collect money from low-income patients, all while enjoying their tax-exempt status. As one nonprofit CEO candidly admitted, nonprofit healthcare is a misnomer. It is tax-exempt healthcare. It still makes profits. This is the system we've built, one that rewards consolidation, revenue growth, and shareholder returns above all else. If you're starting to see the pattern and you think this conversation is important, please hit that subscribe button. We need to keep exposing how this system really works. With all that said, it's easy to feel powerless in the face of such massive, complicated systems, right? But we can't fix what we don't understand. Seeing the system clearly is the first step towards change. If you're a patient, this means becoming your own best advocate. Yes, you have to advocate for yourself. Ask for cost estimates before procedures. Question your bills. And remember that a higher price does not always mean higher quality of care. And also, I want you to challenge the assumption that more expensive is better. It's not always better. For nurses on the front lines, I want you to know that what you're feeling is moral injury, not a personal failing. It's a rational response to a broken system. Document the patterns you see when staffing cuts or profit-driven policies compromise patient care. Record it. Data is the foundation for change. For healthcare leaders out there, the call is to realign your incentives. Stop measuring success solely by revenue per patient. Invest in your staff, promote psychological safety, and build a culture that rewards compassionate care, not just transactions. And for my wonderful students out there entering healthcare, learn the business of medicine. Understand that you may be asked to choose between your conscience and compliance. Prepare yourself, not just clinically, but ethically, for the challenge ahead. The money trail started with a single, inflated hospital bill and ended with a system-wide moral failure. We followed it from the hospital's Chargemaster to the hidden profits of PBMs, from soaring CEO pay to the moral injury of our caregivers. The trail reveals a system working exactly as designed, not to deliver healing, but to extract wealth. The primary loyalty of American healthcare, particularly its largest public corporations, is not to patients. It's to the shareholder, the executive, and the balance sheet. We tell ourselves it's just business. But when business dictates who gets care, when they get it, and whether they can afford to survive, it is no longer just business. We have allowed healing to become a commodity. And in doing so, we've created a system that is profoundly and perhaps intentionally unjust. This conversation is only beginning, because once you see the money trail, you can't pretend you don't know where it leads.